Okay. So, good morning to US and Colombia, and in my place is good evening. So, on behalf of WFNS Neuro-Rehabilitation and Reconstruction Neurosurgery Committee and WFNS Neurotrauma Committee, I welcome all the speakers and attendees on the webinar. So, we have three important speakers with us. Dr. Russell Anju, he will speak on the neurotechniques, nanotechniques in neuro-repair, which is a very important, presently very important topic. Other Dr. Rubiano and Dr. Anupam Gupta will discuss about the rehabilitation and rehabilitation in all developing countries, including in India. It is at infancy level, and I think share of this knowledge will definitely help our patients. And this webinar will be panelists are myself, Dr. V.D. Sinha from India, and Dr. Amit Agarwal, who is head of National Institute in India. The webinar will be coordinated by Dr. Adesh, who is associate professor at National Institute in India. And every speaker will be given 20 minutes and 5 minutes for discussion. So can I request Dr. Adesh Srivastav to start the meeting? And thank you, everyone.
Thank you, sir. So without delaying any further, we all know that neuro-rehabilitation has not been a mainstream topic in any neurosurgical training program. And these webinars actually provide us a great opportunity to understand the current concept and latest technology that is available to our patients. So with the permission of our honorable panelists, I wish to introduce our first speaker, Professor Russell J. Andrews. Professor Andrews is a world-renowned neuroscientist who has been working in close association with giant institutions of the like of Harvard, Stanford, and NASA. And he has chaired and presided over many prestigious organizations and societies. He has many landmark research papers to his credit with various best-selling books and even medical patents. So today he has kindly consented to speak on one of his pioneering works, that is nanotechnology in neuro-repair. Sir, may we please request you to share your experience with us?
Okay, let me get the screen sharing going.
Yes.
Yeah.
Can you see it now?
Yes. Yes.
Screen is sharing adequately. Very good. Well, I want to thank Drs. Sinha, Dr. Agrawal, and Dr. Srivastava for the invitation. And looks like a very interesting session. I'm going to talk about some nanotechniques for neuro-repair, neuroregeneration, and also make comments on stem cells, since they're a very important aspect and it gets down to the nano level. And these days, it's pretty hard to avoid talking a little bit about the COVID pandemic and nanotechniques. Can you hear me okay?
Yes.
Okay. All right. Well, just to review what we mean when we talk about the nano level, you can see on the top there a graph taking from the height of a child down to the atomic level. A nanometer is 10 to the minus ninth meter, but perhaps more importantly than the small size is that nanotechnology really looks at building up materials molecule by molecule rather than cutting things smaller as we usually do as surgeons. And in the last decade or so, the two big ideas in neuro-repair from a nano aspect of nanoscaffolds and neuroinflammation, which is a cellular level process. We're all familiar with what happens in spinal cord injury, and much of what we'll talk about in the next few minutes relates to spinal cord injury, is the problems with cyst formation, glial scar formation, the need to remyelinate the axons in addition to reestablishing the axon contact from proximal to distal or rostral to caudal. If you just look at the bottom there in the blue, the challenges of this disrupted signal, whether it's in the spinal cord, the peripheral nerves, or the brain, And for the axonal regeneration, we really need to bridge that gap with a structure that is linearly oriented to have the axons regenerate in a meaningful method. So the two big principles we're going to talk about today are multifunctional nanoparticles and the nanoscaffolds. Surface patterning is not quite as important, and I already won't delve into that. Again, if we look at spinal cord injury, how do we address this for neuroregeneration? We want to enhance the growth factors that help with repair. Stem cells can do this. We'll look at some of the ways they do this. Biomaterials that can both sustain the stem cells and deliver these growth factors. And you see on the right, electrical stimulation and exercise training rehabilitation, which our next two speakers will be dealing with, and I'm not going to get into that aspect. If you look at the graph in the upper right, the black line shows this massive macrophage infiltration at the early portion, the first week of spinal cord injury and other nervous system injury. These are really pro-inflammatory macrophages and microglia, but there's also a second phase that's somewhat like the blue line, the anti-inflammatory cytokines, where macrophages and microglia are actually supportive of the recovery. We'll get into that a little later, but there's what's called the M1 and M2 phases of the monocyte or macrophage infiltration, one being detrimental and the other being more beneficial for recovery. And this is just an illustration of the detrimental growth in macrophages over the first week. You can see the graph on the upper right. And then there's pictures showing over the actually a nearly 4-month period of a injury model, MRI scans on the left, and then various H&E stains, and looking at the course of macrophage evolution over the first several months following injury. Here we see the first, or the M1 and M2 phases, just shown in by color, pro-inflammatory early phase, and this is looking at microglia, but they parallel the macrophages quite closely. And then the anti-inflammatory or beneficial phase later on. I won't go into the details given this is just a brief overview. Here's a slide showing the really two waves, and interesting, the first wave, in the first week, the pro-inflammatory macrophages are largely coming from the spleen. Not aware of anybody who would volunteer to have a splenectomy if they thought they were going to have a spinal cord injury, but it might be of some benefit. Obviously, these macrophages are released so quickly that you couldn't, I'm not aware of anybody doing a splenectomy as a treatment for spinal cord injury. But again, there's a second wave where the macrophages come largely from the bone marrow, and that's the beneficial that starts after a week or so and benefits the recovery. Turn now to nano level methods. This is one of the main techniques is self-assembling nanopeptide scaffolds. These are amino acids. There's several different kinds, but they all basically assemble into a linear array. And this has been shown not only to be a kind of amazing hemostatic agent, you can just squirt this liquid onto bleeding tissue and it will stop the oozing quite immediately. But here's a cerebral hemorrhage model in a rodent where they aspirate the hematoma and then inject either nothing, saline, or this self-assembling nanopeptide liquid. And as you see here, let's look just at the right, the neutrophils, just aspiration reduces the number of neutrophils infiltrate in that cavity. But the microglia and macrophages are only reduced by injecting the nanopeptides. And similarly, apoptosis is benefited more by the nanopeptides than aspiration or saline injection in the hemorrhage cavity. There's also demonstration that these rodents actually improve, they were hemiparetic and they improve their neurological status on this limb placement test. An even more impressive example of these nanoscaffolds, these are hamsters, whereas you see on the left, they actually make a knife cut in the superior colliculus and blind these animals. C and D are the control animals at 1 day, and actually you should focus on E and F. That's after 1 month, the E being a control animal and an F being one who has this self-assembling nanopeptide injected into the lesion site. And amazingly, about 3/4 of these animals actually had functional return of vision, really quite impressive. Similarly, another animal model, a lesion in the visual system, you see here in the breaking of the superior colliculus, and this is using manganese enhanced MRI to trace the fibers. And in this slide, you see a blow up in D, E, and F of the A, B, and C. D being the pre-lesion animal, the optic tract, superior colliculus. E being the lesioned animal, and you can see the collection of the contrast agent in the optic tract just up to the lesion. And then when the nanopeptide has been injected, there's some bridging across this, and again, functional recovery. Now, in peripheral nerves, you can use the same, again, self-assembling nanopeptide array. This is a 1 centimeter gap in a peripheral nerve with a conduit placed, and the conduit's filled in C with the nanopeptide liquid and in D with saline. And if you look at the panels 1 to 5 in C and compare it with D, there's much more linear orientation of the fibers in C. And as we see in these graphs here, there's a much greater number of axons that actually bridge that gap. Now, if we turn now to nanoparticles, this is a model where of spinal cord injury where they're delivering polymeric nanoparticles intravenously, and these particles are uptaken by the macrophages. And as we see in the next slide, what happens here is it encourages these macrophages to be taken up by the spleen, which is where they frequently are in the early phase, are released from in the detrimental phase of inflammatory response. If you look at the bottom, the naive animals or the uninjured animals, the spleen and spinal cord show no evidence of macrophage uptake. But in the sham animals that are not operated but have the nanoparticles injected, these nanoparticles being ingested by the macrophages tend to make them be taken up by the spleen, but not in the spinal cord. But interestingly, in the spinal cord injury model, there's some macrophages at the lesion site, and these are the beneficial macrophages. If you look at the graph on the upper right, again, the Basso mouse scale is a measure of functional recovery, 0 being complete paresa paralysis, and 9 being complete normal hind limb motor function. There's improvement in the nanoparticle injected macrophage model. Look now at the clinical aspects of spinal stem cells for spinal cord injury. You see here in India and China are the 2 major centers for these trials. Some of you may be familiar with this article. It came out recently in neurosurgery, but there's really some trials going on in many countries in the world. If you look at in A, about 1/3 of these trials, the cells are injected intramedullary in the spinal cord, about 1/3 intrathecal, and much fewer used intravenously. And if you look at the bottom right, about 1/3, only 1/3 have rehabilitation programmed into the trial itself. And then in the bottom left, you see the follow-up is generally about 2 years following the treatment. This is a slide just showing some of the different types of stem cells, neural stem cells, mesenchymal stem cells, embryonic neural stem cells, pluripotent, Schwann cells, olfactory sheathing cells. They all have been tried. The majority are mesenchymal stem cells in most trials. If you look at the upper right, exosomes are quite an important aspect, which we'll look at in just a few minutes. They are extruded from the stem cells, and they contain proteins and messenger RNA genetic factors that can be quite anti-inflammatory, anti-apoptosis, and angiogenic. And looking again at the clinical trials, most of them, or the majority, involve mesenchymal stem cells in red, followed by the mononuclear progenitor cells in green. and about 2/3 of these are autologous stem cells. If you look at mesenchymal stem cells, you can see I put asterisks up at the top there. The majority are taken from the bone marrow, but some studies look at umbilical cord and adipose as a source. And then in the bottom, you can see the various tissues that these can differentiate into. And for those who like to read rather than look at pictures, this just demonstrates some of the effects of stem cell transplantation, in this case, mesenchymal beneficial aspects. And looking at these a little more geographically, what we'd like to do, rostral to injury to improve function at the injury site, and caudal to injury. Again, the big themes being remyelination, reduction of glial scar, and providing a cytoarchitecture which will enhance the axonal regeneration. Just to look at the effect of not the stem cell itself, but indirectly, this study of spinal cord injury showed that particularly CCL5, which is a factor that encourages cells to go to the appropriate places within the nervous system. It's a chemokine, or seen there, a chemotactic cytokine, again, chemotactic directing the cells. And you can see the lesion, HBSS is Hank's balanced salt solution, basically saline, and then the mesenchymal stem cells, there's a what you call laceration of the spinal cord, and then just distal to it, about one level below at T10 rather than T9, was where the mesenchymal stem cells or saline was injected. And you can see at day 14, there's much less scar in the stem cell model. And below that, you see that there's actually microglia macrophage clustering, not only at the injection site, but also at the injury site. And again, if you look at the bottom left, there's a functional improvement as well, that Basel-Mouse scale. Again, there's the more hind limb function in the treated stem cell treated animals and the controls. These exosomes, as I mentioned, are really becoming quite a hot topic. It's a non-replicating lipid bilayer spheroid structure that released from prokaryotes and eukaryotes. And you can see in the top the source cell, the endosome formation, and it uptakes messenger RNA and proteins, other factors into a multivesicular body, which is exocytosed, and then ideally taken up by the target cell, and these moieties are released with the functions you see in the upper right. I won't read through them. In the middle, you see a kind of a blow-up model of an exosome containing the proteins, nucleic acids, and enzymes, and the various surface markers. And in the bottom, you see three main potentials for these exosomes. One, delivery of these moieties into the patient and directing it to the, say, the nervous system, for example. In diagnosis, you can look at blood or CSF, and there'll be some changes in exosomes in many types of cancer, for example. And then in therapy, delivering to the brain, heart, skin, the nucleic acids or proteins that can be beneficial. And this slide just shows you that the exosomes are really everywhere in this stem cell research now, and cardiac repair, wound healing, tumor, autoimmunity, and closer to our hearts as neurosurgeons, TBI, even degenerative disc disease. And these days we look for applications in the pandemic as well. Just one example of some of the techniques being used. This is an interesting study where you take the mesenchymal stem cell and actually fuse the membrane from the macrophages to it to form a vesicle, which they're calling a membrane-fused exosome mimetic, like an exosome nanovesicle. This is an intravenous injection into a spinal cord injured mouse, as you see in the bottom right. And here's if you look at the bottom, there's the normal spinal cord on the left, the injured, and then as we move right, the nanovesicles, and then the membrane-infused nanovesicles being much more functionally intact or repaired than the others. And you can again see that Basel-Mouse scale in the upper right, more functional improvement in the membrane fused, again, take membranes from the macrophages and fusing into these nanovesicles or exosome-like bodies. And in the upper left, you see gross specimens. COVID-19, we're all familiar with the the actual virus itself. But just to briefly review how they infect a cell and replicate, the upper left, you see it being taken in, endocytosis, primarily with the angiotensin converting enzyme 2 receptor, then replicating intracellularly, and mentioned where hydroxychloroquine and remdesivir have such beneficial effects in interrupting this process. And the virus replicates and then packages itself and is exocytosed from the cell. This is what we'd like to interrupt. And there's various nanotechniques for doing this by incorporating bacteriophage or polymeric nanoparticles or lipid nanoparticles to encapsulate the vaccine. Typically, it seems like the most successful ones are messenger RNA vaccines, since it's an RNA virus. And you see on the bottom how this is, occurs. I won't go into great detail, again, time constraints. But here is a blow-up of that process. Interestingly, both the Moderna and Pfizer vaccines have just been recently quite dramatic beneficial results as vaccines are lipid nanoparticle based RNA, a messenger RNA based. And you can see that basically the goal is to interrupt that replication process intracellularly by infusing the messenger RNA through the lipid nanoparticle. And in the upper left in this slide, you can see the lipid nanoparticles with the messenger RNA. And in it, you can also put in peptides or proteins. You can conjugate rather than incorporate the peptides in the lipid particle, or you can use a virus-like particle or a polymeric spheroid to incorporate, again, messenger RNA or proteins that you'd like to deliver. Moderna has been working on this for a number of years, and you can see on the right-hand side, they found this lipid 5, which is one of the best substances for constructing this lipid bilayer to incorporate the messenger RNA and actually not get degraded before it gets intracellularly. What we'd like to do, obviously, is get beyond the need for these vaccines to need cold storage. As you know, the Pfizer vaccine needs a much colder storage than the Moderna vaccine. But we'd like to get to the point of what we see on the upper left of either a virus-like particle vaccine that can be at room temperature or near room temperature and injected in standard intramuscular, intrasubcutaneous fashion, or in the upper right, ideally get a degradable microneedle patch that individuals just place on their skin and that would gradually dissolve and inject the vaccine over time. So with that, I think I'm probably getting short on time, but I just want to reinforce the two big areas that where nano can contribute to this are nanoscaffolds for axonal regeneration and these multifunctional nanoparticles, which have increasing number of applications in neuro-repair. And finally, I want to thank my colleagues at the NASA Ames Research Center Nanotechnology. You can see in the upper, on the left side, that's Maya Mayapan, who's now the chief scientist for exploration technology at NASA Ames. Jessica Caney, and on the right side is, she really runs the lab that the postdocs and others work in on the Nanotechnology Center. And also Krishnan Ganapathy, who some of you may know is a neurosurgeon in Chennai that I've been fortunate to know for a decade or more, and he's actually visited NASA Ames. He's head of the Apollo Telemedicine Networking Foundation, a very forward-looking fellow, and we got him together with Cisco Systems to try to integrate Cisco's capabilities with the Apollo Networking, Telemedicine Networking Foundation. That has not been too successful, thanks to Cisco being a little too, wanting too much bandwidth, but there's a lot going on, as all of us know, in India in various fields, and I think in nanotechnology as well. There's many centers working in the fields that we're working on. So I think I'm out of time, and look forward to any questions you might have, and thank you.
Thank you, Professor Andrews. And that was indeed a very thought-provoking, and we shared new insights about such an exciting new arena for treatment of our patients who have been suffering for so long. This definitely holds a lot of promise for them in the future. Now, I think with the permission of the chair, can we take up a couple of questions that have come, sir?
Yes.
Yeah. So first question is from Dr. Rakesh Mishra. He says, thank you, sir, for the very enriching and thought-inspiring talk. He wishes to know two questions he has posted. First is, can nanopeptides inhibit apoptosis of normal cells by modulating immune response in case of traumatic brain injury or spinal cord injury? The second part of his question is, nanoparticles show promise in which pattern of injury, whether it is more promising in cytotoxic injury or in injuries leading to demyelination. Over to you, sir.
Well, with regard to the first question about the apoptosis, yes, I think I showed one slide where apoptosis that was in the hamster, actually, I'm not sure it was the rodent model of intracerebral hemorrhage, that there was a decrease in apoptosis in the self-assembling peptides. The second question, there's certainly work going on in say neurodegenerative disorders as opposed to acute trauma. And I think it's not as far developed. It seems like spinal cord injury is the kind of the most crucial model for neuro-repair, in that the results of a spinal cord injury are so dramatic and such a great impairment to people that, and it's a kind of a limited injury, very focally oriented injury. And so I think there's been more work in that area, but I'm not sure there's more potential in that area than whether it's post-stroke or
post-demyelination
disorder, peripheral nerve.
Yeah.
I don't know if I've answered your question, but.
Can I ask Dr. Russell, can I ask any role of 3D bioprinting scaffolds in this technique?
So role for what? I'm sorry. Please repeat.
Any role of 3D bioprinting scaffold techniques? Or
well, there's some work on the surface patterning in, say, peripheral nerve regeneration.
okay.
I didn't get into that. Again, it's not nearly as well developed, but I think especially with 3D printing being increasingly application, I think that there will be roles for that. Again, I think probably peripheral nerve regeneration is going to be because you could form a little conduit with the biopatterning, and that's people are working in that area particularly.
Okay, thank you.
So, so we don't have any further questions as of now. As the questions come in, we'll be taking them up. Sir, if you permit, can we move on to our next speaker?
Yeah, sure.
Yeah, thank you, Professor Russell. And we now have our next speaker. We have today with us Professor Rubiano from the University of Colombia. Sir, we thank you for taking out time from your busy schedule and accepting our invitation to be a part of this webinar series. Professor Rubiano, after his training in neurotrauma and clinical research in the United States, returned back to Colombia. And since then, he has been extensively working in trauma, emergency, and neurocritical care. He has numerous publications on the subject and actively participates in various international collaborative groups that advocate global neurosurgery. And today, Professor Rubiano shall be speaking on global perspective of neurotrauma rehabilitation, the present and future. Sir, over to you.
Hello, everybody. Thank you, Professor Chivastava, and also my good friends, Dr. Sinha, Dr. Agrawal, also Professor Russell, and also Professor Gupta, who will be sharing the panel with us. Thank you for the kind invitation. I'm going to speak about neurotrauma rehabilitation, present and future. So did you see my screen right now, or I need to share the screen?
You need to share, sir. Not yet visible.
Okay. Okay, so you have my screen right now?
Yes, sir. Thank you.
Okay, perfect. So I don't have any conflict of interest, just some of the work that we have been doing locally here is supported by the NHR with the Global Health Research Group on Neurotrauma Initiative from the University of Cambridge and our research center in Colombia, Meditech Foundation. So talking about neurorehabilitation will be very important to understand the magnitude of the problem. So we all know from the Global Burden of Disease study that neurotrauma is a very important problem around the world, especially in LMICs. The global burden has been represented mostly for LMICs, especially regions like Central America, South America, Southeast Asia, and also Africa. We recently published this review regarding the estimated global incidence of TBI. We know that the of registries around the world, we need to have more data, more organized data. We have really good examples of organized data collection from LMICs, like the data collection that you are performing in India, and also some exercises that we are performing in Latin America. So now an important risk factor is related to road traffic collisions, and especially motorcycles all around the world. So when we speak about neuro recovery, we need to take into account that in typical cases of severe TBI, the natural history of recovery allows to a period of impaired consciousness, sometimes paroxysmal sympathetic activity, post-traumatic agitation or confusion with amnesia, and then a period of post-confusional recovery of function with a diversity of cognitive, behavioral, emotional, and sensoriomotor disturbances. Then all these issues, the medical aspect is confronted with how the individual course of recovery and in which point of the recovery rehabilitation is initiated. The definition of new approaches to the acute and chronic phases of this problem, including the most appropriate timing for starting, play a key role to optimize all the interventions. So the exploration of the effects of neuro-rehab on plasticity using advanced technologies like biomarkers, DTI, NIRS, represents an actual surrogate outcome that we need to take into account when we evaluate all the impact of these conditions. So following what Professor Russell has mentioned before, it's very important to understand all the neuroproteomics behind this. And this is just to mention some example about the role of calpains and also caspases inside the process of recovery and also the process of injury itself, leading to that apoptosis that has been mentioned before. Going into the biomarkers pathways, now we understand very well that this is a chronic phase process of recovery that will take until almost 2 years after the injury. And this is a very important process that we need to take into account in neurorehabilitation, because sometimes the family pressure and also if we didn't understand very well how this process is going on, is that we want to see immediate results in the first week after the injury. And we definitely need to understand that all that process that Professor Russell has mentioned, it takes a long time, especially months and over at least a couple of years. So understanding how these biomarkers that show us the neuroregeneration process evolve will be very important process to follow the whole rehabilitation. So there has been some specific biomarkers that have been identified in the neural repairing process. We have, for example, the BDNF, the brain-derived neurotrophic factor. We have also the CNTFR, the ciliary neurotrophic factor receptor. We have the NGF, the nerve growth factor or beta polypeptide. And we understand that how all these biomarkers behave in the time after the injury. So we also can correlate some of these with new technique of imaging like the DTI that we mentioned before. Tractography have been evolving a lot in order to understand how the recovery patterns have been activated after the injury and during the neuro-rehab process. So we have here some of the work that have been doing by Professor Singh and Young from the Southern California, University of Southern California, following these patients for an important period of time with DTI. And you see how the normal controls compares with the patients after a TBI. There is an important contribution also in diffuse axonal injury patients. We have here some example of the local Latin American group of the University of Sao Paulo, where they are following these patients, evaluating how the area of more affected zones can evolve over the time. So if we want to set an actual context for neuro rehab, we need to understand a lot of important issues related to the rehab process in the world. Luckily, the World Health Organization have a specific area working into this topic around the world, and they have identified important gaps in the care of patients around the world. Now we know that at least less than 10 skilled rehabilitation practitioners are available per 1 million of people in LMICs especially, so we have a lack of appropriate training process for following these patients. It has been estimated around 40 to 50% of patients that are hospitalized as a result of the acute, moderate, or severe TBI can show long-term disability, but we don't have the resources to follow very good these patients. So we have this big gap regarding of where are we settled. This image that we have in the right side of the slide regarding starting early rehabilitation process, even inside the ICU with appropriate equipment, is not the most common procedure that we find around the world. We regularly don't have too many resources, or sometimes there are a lot of issues. For example, that knowing that rehab help patients to be as independent as possible in everyday activities, and also enable them to participate in education, work, recreation, and other life roles like taking care of families, because we know that this problem of neurotrauma is more focused on people that is economically productive, taking all the resources to families that are affected. So the need for rehabilitation around the world is largely unmet. It has been estimated that at least 2-4 billion people are currently living with a health condition that could benefit from rehabilitation, but not all of them have access. And in some low and middle income countries, more than 50% of people do not receive the rehabilitation services that they require. Now, also mentioning something that was mentioned by Professor Russell, is in the actual COVID-19 pandemic situation, most of the established rehabilitation services have been disrupted, at least in around 60 to 70% of the countries that were developing these services. So the actual barriers that we have is there is lack of prioritization, lack of funding, lack of policies and plans for rehabilitation in national levels. There is a lack of available rehabilitation services outside urban areas especially, and there are long waiting time for the patients in order to access to this early rehab process. There are huge or high out-of-pocket expenses, and there is not existent or inadequate means of funding for these patients. There are lack of trained rehabilitation professionals. We already mentioned this data, less than 10 skilled practitioners per at least 1 million population in LMICs. There is lack of resources, including assistive technology, equipment, and consumables. The need for more research on data and rehabilitation is clear. We are just in the phase of starting this clinical registry for understand what is happening during the whole integral pathway of care for neurotrauma patients. And regular rehabilitation is the area that is most affected about the not availability of data, also like in pre-hospital care sometimes. So they're ineffective, have underutilized referral pathways to rehabilitation. So because of this, the World Health Organization had developed this plan that is called Rehab 2030 Call for Action, as always supporting and trying to call attention from local governments in order to enhance rehabilitation from at least 10 key activities, like creating leadership and political support for rehabilitation at national level, strengthening rehabilitation planning and implementation in national and subnational levels, improving integration of rehab into the health sector, and strengthening all the intersectorial links to meet appropriate population needs. Also incorporating the concept of rehabilitation into the universal health coverage plans, because in most LMIC, the insurance process and also the public system that allowed support for care of this patient does not pay in full for rehabilitation services. Also to call for building comprehensive rehabilitation services, developing a strong multidisciplinary rehabilitation workforce, expanding financing for rehabilitation, collecting information relevant to rehabilitation, building research capacity, and establishing a strengthened network of partnership in all the rehab process. So knowing about rehabilitation as itself, you have this pyramid of going from very specialized high intensity rehabilitation processes that are normally required by most severe neurotrauma patients, even in spinal cord injury that had been mentioned before, or also in severe TBI. And ideally, many of the patients that arrive for tertiary care in all these countries can start this specialized high-intensity rehabilitation as soon as possible. But we all know that sometimes this is not possible. So then these patients are waiting for rehabilitation in a specific medical specialist in tertiary or secondary healthcare after they left the ICU, or sometimes they just allowed to have access when they are integrated back into primary health care after discharge of the hospital, or sometimes they only have access for community delivered rehabilitation that has been shown that is also effective, but when it's delivered early, as soon as possible and not late. And if not, sometimes we have this process of informal and self-directed care regularly performed by relatives, or sometimes supported by tele-rehabilitation programs. So when we have all these programs evaluated, looking for some sort of evidence regarding the impact of these programs, we really know that the best quality of evidence is showing that the intensive rehabilitation very early in the intensive care unit is the most recommended one, but is the most expensive sometimes, or the resources are not there, and not all the patients are entering into this process. With a moderate high quality of evidence, we have the specialist rehabilitation process. They allow to improve independence and reduce ongoing care. They have some gain in productivity, especially vocational programs. With moderate and low moderate evidence, we have all these community-based interventions. We have the late and ongoing rehabilitation programs that allow at some point to maintain independence and productivity. But as we compare this with the pyramid, we know that at least more than 50% of the patients do not have access to the first steps that are the steps that have the high quality about evidence of interventions. So when we evaluate most of the studies that have been performed worldwide, we understand that a multidisciplinary rehabilitation for neurotrauma in adults of working age, that is the most affected population, we already confirmed that intensive interventions are the lead to early gains. Earlier intervention, even when they are still in emergency and acute care, have been supported. There is not much evidence from LMICs. Most evidence is coming from high-income countries. The balance between the intensity and the cost effectiveness needs to be determined. We already mentioned that regularly for LMICs, there is a lot of expenses and out-of-pocket expenses if the patient wants to have this sound rehabilitation process. So patients are discharged from inpatient rehabilitation. They benefit from access to outpatient of community-based service, but not as much as the early acute intensive intervention. And the group-based rehabilitation in therapeutic milieux, like when patients go for a specific tracks of neuro-rehabilitation, like neuropsychological rehabilitation or other, represents an effective approach, especially for these patients that have cognitive disorders. It's very important to see how even this problem comes from high-income settings, and this recent survey from the Center TBI study in Europe is really interesting, because you can see how even in most European countries, in centers that have been organized for taking care of these patients, most of the persons, or at least the centers and providers and also families, are not really like satisfied with the whole process. And talking about a specialized neurorehabilitation, most of the people just have like some were satisfied with the process, There are common situations like still in these areas, patients need to move big distance from patients' homes in order to enter into these services, and the quality of care sometimes is not as good as required. When you see also how each one of these centers perform in tasks like organizing rehabilitation from the beginning, or transferring the patient to nursing homes or psychiatric hospitals or outpatient facilities, there is a huge variation between the centers and how the persons or the patients arrive into these neuro rehab processes. And at least, if there is a very important issue also, at least 90% of the centers, this was surveyed between 70 European centers, use rehabilitation guidelines in patients with traumatic brain injury. You know that following guidelines at some point has been related to improving outcomes, but it's clear that not all the centers are following specific pathways of recommendation from experts regarding how to perform this rehabilitation process in neurotrauma. We have really good quality recommendation from different guidelines around the world. This is just to show some example for the clinical practice guideline for the rehab of adults with moderate to severe TBI from the Ontario Neurotrauma Foundation. We know that the Ontario Neurotrauma Foundation is a foundation working specifically for neurotraumatology, supported by the Institute of National Excellence in Quebec. And it will be very important to start developing at least some similar recommendations for LMICs. We know that for the actual guideline that India have, for example, they have some discussion regarding early enter to rehabilitation recommendations, but we didn't know if all the centers are following this pathway. So considering the heterogeneity of the physical, cognitive, behavioral, and psychosocial sequelae after TBI, neuro-rehab has to have an individualized and focused approach on the patient's aims, needs, resources, and deficits, according with some standard classifications like the International Classification of Functioning, Disability, and Health. So when we move to the trends that just Professor Russell have been mentioning about all these nanotechnologies and stem cells involved into the late process of neurorehabilitations. So we know that traditional neurorehabilitation procedures may have limited efficacy in most of these patients. New technologies have been reported to enhance the effectiveness of rehabilitation strategies in neurotrauma. We have now all these new robotic assist training, virtual reality, functional electrostimulation, non-invasive brain stimulation that at some point can enhance the intensity and quality of the neurorehabilitation process, allowing to manipulate brain excitability and plasticity. So the correlation between central nervous systems injuries and clinical features and outcome represent the basis for something that is the future for this patient, that is personalized neuro-rehab according to how the plasticity moves in each one of the cases, being a promising perspective to explain the differences between individual response to the treatment and improve according to the quality of care. So this is just a brief image of how some centers have been dedicated to advanced neuro-rehab, including virtual reality and robotics into the process of management of these severe TBI patients entering into an acute phase, mostly and not also for just chronic cases. So to finish, we just need to remember that surgery is just the beginning of these journeys for all these patients and their families and relatives. And we need to be aware that neurorehabilitation is a very important process. The World Federation of Neurosurgical Societies has been very pushy regarding the possibilities to generate awareness between the neurosurgeons taking care of this patient to participate. And thanks to Professor Singha for being president of this committee and try to arrive in every corner of the world to maintain the message that we need to continue doing this process all the time. So thank you so much.
Thank you, Professor Rubiano, for giving us such a wide perspective of the current status of neurorehabilitation globally. With the permission of the panelist, can we begin questions?
Can I ask? Okay, Dr. Rubiano, can I ask, because in developing countries, including India, there are very few neuro rehabilitation centers, and all the rehabilitation is given by the family caregivers. So, you have made any guidelines for that area? Number one. Number two, how the rehabilitation in pediatric cases is different from adult. Just for yes, few youngsters on webinar, they should know.
Okay, thank you for the question. So for the first question, definitely that is a worldwide problem, as you mentioned, that in most LMICs, we have this rehab performed by the caregivers or even some long-term facilities where there is not always people specialized in the neuro-rehab process. Uh, we need to promote actually the developing of more specialized centers. What we have here, for example, in the Latin American region is the few centers that exist are very expensive and people does not have sometimes the means to go there to support the payment from their out-of-pocket expenses. And I think the federation plays a really important role, you know, creating this awareness of the why we need these centers in all these different regions. We definitely need to move to developing more specific guidelines with the active participation of neurosurgeons in the development of these guidelines. We are now moving for a second phase of our stratified protocols that we are focused right now on the initial part of the management, but definitely what we are doing is preparing for the next step of following these stratified protocols of care, introducing the guidelines for rehabilitation. So I think knowing or your leadership and also Professor Agrawal's leadership, the idea is that we can move ahead and try to work together in order to develop some of these guidelines because we share many of the same conditions in many LMICs. So for the second question regarding pediatrics, fortunately, it's very clear that pediatric advance faster in the rehabilitation process, and we need to also start as soon as possible this because the plasticity, it seems to be bigger. They have more availability of the stem cell process development for neuroregeneration and also for connection, the neural network, supporting some of the talk that has mentioned by Professor Russell, and definitely even pediatric patients needs to be involved in this same track of early rehabilitation. And it seems for the few studies that have been done that these patients definitely arise soon to a better care point and a better developing point after the trauma.
Thank you, sir. This
Dr.
one.
Dr. Rubiano, I am Dr. Amit Agarwal. I would like to share the same concern what Dr. Professor Sinha has shared. What all the scope and opportunities for collaboration in terms of understanding traumatic brain injury related issues, particularly rehabilitation? How can we come together and collaborate?
So I think definitely now we have a very interesting opportunity with effort that have been done, like for example, this Global Health Neurotrauma Research Initiative from the University of Cambridge, where some centers from India and also from some other Asian countries have been integrated. We have now 3 countries that are going to be for the next round of funding, and rehabilitation has become a very key topic in order to understand how these patients that have been taken care of initially with, you know, like surgical procedures or even advanced clinical procedures are performing, because we really didn't know about it. So now we have this nice opportunity. This is an open invitation for the Global Health Research Group in Neurotrauma in order to open doors for people that want to work with us into developing these guidelines and also developing the clinical registries for define specific pathways of data collection to understand the big picture of what is happening with these patients. Some preliminary studies in LMICs, like for example, some of the studies that have been performed by the group of Nancy Carney in areas like Argentina and other countries in the South American region, have been identified that there is really a lack of early access, even in pediatric population, that are entering really late into the formal rehabilitation process. And as Professor Sinha mentioned, they are regularly taken care just by relatives and families inside their homes, with sometimes not a specific guidance process of therapy. Now what we have with the opportunity of cell phones and virtual reality access from cell phones and mobile phones, we have also a golden opportunity to integrate and direct specific therapies for early rehab in these patients.
Thank you, sir. We have a participant query who wishes to know your views whether all TBI patients should undergo a psychological rehabilitation as well, irrespective of their symptoms.
Okay, thank you for that interesting questions. And to answer that, we need to settle the context or where we are. And this is very important, and we learn a lot now studying the stratified protocols of care. And is that when we think about possible factors that have been associated with the injury, but we did not have the technology to evaluate them, the patients will benefit for this type of approach. That is that when you don't have the resources, you know, to do like a specific functional MRI, when you don't have the technology to develop some, for example, tracking eye figures for understand these connections in the neural network, most of the patients will beneficiate for early general approaches, like, you know, starting neuropsychological evaluation and also doing a specific cognitive rehabilitation, even if we don't have these symptoms. Because what has been identified is that even in most mild cases, you have a small disconnection of the network, especially in areas like the prefrontal cortex and also the secondary motor cortex. And all these affects even mild processes of functioning that we didn't identify very well even in the clinical exam. You know, like some patients have, we understand now, following all these patients from the compressive craniectomy surgeries, that, you know, patients have, for example, loss of initiative. And if they are in the school, or if they are in the university, or if they are working, sometimes they have difficulties in the work, and some then get fired because people didn't understand that they have these mild symptoms that are not intervened early. So definitely in most patients, if you don't have a specific way of measure the deficits, you can beneficiate the patient for an integral approach, including early cognitive rehabilitation.
Thank you, sir. So one final question from Dr. Sumit Raj is regarding music therapy and for the treatment of patients of TBI, and your experience regarding the same.
Okay, this is also a very interesting question. And sometimes we, you know, as neurosurgeons, we minimize all the processes that have been related to neuro-rehab. And I think musical therapy is something that integrate at some point some pathways in the brain. What we have been evaluating right now, you know, doing eye tracking for even mild injuries, is that when you stimulate different regions of the cortex at the same time, you even move to stimulate far forward areas of the brain that you even didn't think that were stimulated by this. So when you do musical therapy, you also stimulate areas that you maybe think that are not connected, but we all know that it's really well connected to cortical patterns. So you can stimulate even areas that are in the frontal lobe. You can stimulate areas that are in the occipital lobe, doing some stimulation from the parietal and temporal cortex. So definitely what we are doing right now is even in the ICU, as very early, we start putting music and many other stimulation process in the ICU. You know, we sometimes put headphones in the patients, even if they are in the first week or second week of the injury, when we start waking them up to have, like, we ask the families to see what is the favorite music of the patient, you know, to have all these emotional stimulus that can generate a better reaction of the brain. And also it seems that this generate plasticity early in the process. So definitely all these stimulations in different pathways, you know, visual pathways, ER pathways is definitely very important for the rehabilitation of patients.
Yeah. Thank you, sir. Now, one last query. I'm sorry that I'm extending it a bit. One minute query to you, sir. When we began this webinar, I mentioned that neuro-rehabilitation is not a major topic for in any of the residency programs, as you know. So do you think making neuro-rehabilitation as a major topic mandatory in all neurosurgical residency programs, or mandatory a neuro-rehabilitation center as a mandatory part of any neuroscience center, would it make any change, and what's your take on that, sir?
No, totally. And that's why I consider a very important process what Professor Sinha is doing with the Neuro-Rehab Committee, because definitely we need to understand or allow to understand the younger generation that integral care of TBI or integral care of spinal cord injury include the rehabilitation process. You know, sometimes we as surgeons, we minimize the post-operative care, and we say, okay, now these patients was already taken by the rehab services, and that's it. And you never continue following the process of care for your patients. So if you do a very early intervention surgically or medically for severe TBI, it will be ideal because you already established some ties with the families of the patients. So many of these families arrive to you and say, I want your opinion into the neuro-rehab process. What are the next steps? Are you going to be involved into that? And if the younger generations understand that this is a continuous pathway of care and we need to see the integral care of the patient from the system perspective, outside from the different actors and not just centered into the surgical approach, definitely these patients have like better outcomes. So as you mentioned, having the possibilities of the residents to rotate in excellent centers, in neuro-rehab centers, will change the whole picture about how we perceive the recovery of these patients. Just one brief concept about an example about that is that when we talk, for example, with surgeons, with neurosurgeons about early surgical management of the patient, sometimes they say, I don't perform X procedure or this procedure, I don't perform this medical intervention because most of my patients after that are discharged from the hospital in a very bad shape. They are vegetative or something like that. But they never see the patients 6 months after or 12 months after or 24 months after. And we now understand this because of the biomarkers and also the advanced imaging that these patients recover almost until 2 years after the trauma. So when you don't see the real final impact of your early intervention, you think in your mind that this is a worthless process. So when you have the possibility to see in neuro-rehabilitation centers how a patient that you operate 1 year ago is start walking again or is start performing tasks and activities of daily life again, you don't understand how is the big impact that you are doing in the early stages of care. So definitely it's something that we need to promote. Is something that we need to understand in order to see the advantage and the very important process associated to the initial management.
Thank you so much, sir. And you very rightly said that all of us as neurosurgeons have seen this thing, that a patient which has been sent home or to care with the surgeon thinking in the mind that we may never see this patient. The patient comes after a few months, shakes hands, and you see him walking, talking, and we like that. I mean, every one of us has seen that. Thank you so much, Dr. Rubiano.
Just a comment I want to give. In our department, we have a space where we have written the neuro-rehabilitation space. So all the patient, the physiotherapist come and teaches the neuro-rehabilitation to family person. So it helping so much for outcoming of this patient that there is drastic changes when they come to our OPD. So all the family person are taught the rehabilitation from physiotherapist, and they do so vigorously, and from heart they do so well neuro-rehabilitation. this patient, that we can see the outcome of this rehabilitation when they come in OPD. So,
Sir.
so we must, all neurosurgeons should promote neuro rehabilitation, then only this will be beneficial.
Very true. Very true, sir.
Yeah.
So with your permission, can we move to the final talk of the day?
Sure.
Yeah. So finally, we have with us today Professor Anupam Gupta, who is the professor and head of Department of Neuro-Rehabilitation at the National Institute of Mental Health and Neurosciences, NIMHANS, Bengaluru, India. Dr. Gupta has more than 2 decades of experience in the field of neurorehabilitation, with more than 75 publications on the subject to his credit. With various books on the topic, Professor Gupta shall be speaking today on a very crucial aspect of neurotrauma rehabilitation, that is urinary bladder. So now I would request you, sir, to please take over and give us some insights on the challenges of bladder rehabilitation after neurotrauma. Over to you, sir.
Thank you, Dr. Adesh. And at the outset, I would like to thank Dr. V.D. Sinha and Dr. Agrawal also for inviting me for this topic, talking about the challenges of urinary bladder rehabilitation following neurotrauma. So what is a neurogenic bladder dysfunction? A neurogenic bladder dysfunction is a malfunctioning urinary bladder, which has happened as a result of neurological illness, disease, or as a result of trauma, whether it is a traumatic brain injury, and more importantly, in most of the cases, in traumatic spinal cord injury. The International Continence Society defines neurogenic lower urinary tract disinfection, which includes urethra also, as lower urinary tract dysfunction occurring as a result of disturbance in the neural control mechanism. So if we look at the bladder neuroanatomy, the efferent pathway is under autonomic control, and we know in response there is a Barrington center, and that's how we divide the bladder control into suprapontine, pontine, and local at the level of sacral region. So bladder innervation is both sympathetic and parasympathetic. Sympathetic innervation is through hypogastric nerve D10 to L2, and this is responsible for bladder filling and relaxing the bladder wall. Whereas the parasympathetic innervation, if you look, it has one pelvic nerve, which is parasympathetic control, which is responsible for detrusor contraction, which results in micturition. And we have a pudendal nerve, which controls the external urethral sphincter, which is under voluntary control. The afferent pathway, the sensations from the bladder are taken through A delta fibers, which are the small myelinated fibers, and the C myelinated, unmyelinated fibers, which are usually considered to be silent fibers, not functional. But in extreme chemical or cold stimuli or after trauma, say spinal cord injury, they become activated, and in fact some of the drugs work on it, like capsaicin and resiniferatoxin. So if you look at the normal control of bladder, the normal micturition, the bladder is basically a storage reservoir. 99% of the time bladder is collecting urine. So filling or storage phase, what happens? The detrusor is relaxed, bladder neck is closed, external sphincter is also closed. But when the person wants to void, in the voiding phase, what happens? Detrusor contracts under parasympathetic control, bladder neck relaxes, which is under sympathetic control, and external sphincter, which is under voluntary control, is relaxed, and urine is expelled. And towards the termination of voiding phase, what happens? Any urine which is there, it is taken inside because both the external and internal urethral sphincters are closed. So as I told you, we divide the neurogenic bladder dysfunctions into the 3 categories: suprapontine lesions, pontine lesion, or infrapontine or spinal lesions, and infrasacral lesions. Suprapontine lesions would predominantly produce storage symptoms. I'll tell you in the subsequent slides what are the storage symptoms. So here we expect the patient must be having neurogenic detrusor overactivity without dyssynergia. That is the usual thinking in the suprapontine lesion. And the most common lesions being stroke, especially in the initial 6 to 8 to 12 weeks, Parkinson's disease in the later stages, Parkinson's syndromes, it may come very early, especially in patients like MSA, patients with dementia, tumors, and of course, traumatic brain injury. Infrapontine lesions, like most common being the traumatic spinal cord injury. In fact, traumatic spinal cord injury along with multiple sclerosis and meningomyelocele would constitute the majority of neurogenic bladder dysfunction across the world. These are the 3 most common factors for producing neurogenic bladder dysfunction. Then there are some tumors also, primary or secondary, which can produce neurogenic bladder dysfunction. Infrasacral regions could be in the form of disc prolapse, pelvic nerve injuries, diabetes, and all that. But this is the conventional wisdom. But what actually happens? This is just like our study with stroke patients. As you can see, these stroke patients, when they were admitted with us in rehabilitation, had urinary complaints, had urinary incontinence. And we did neurodynamics in all these studies. And as you can see in this table, 25% of the patients had dyssynergia, which we conventionally believe should be in the infrapontine lesion. But here in these patients had urinary complaints, but DSD was also present. In fact, some of the patients had underactive detrusor, or one patient was found to have normal steady. Similarly, in patients with Parkinson's disease and PSP patients, again, you would believe the patient would be having suprapontine lesion, and according to basic ganglia lesion, the patient must be having without dyssynergia. They had urinary complaints. We did the urodynamic studies in them, and as you can see, a lot of patients had normal detrusor, as well as few patients had dyssynergia also. So it is also theoretical. Patients with suprapontine lesion can also have DSD. They can also have underactive detrusor also. So what are the sequelae of neurogenic bladder dysfunction, especially in spinal cord injury patients? Traumatic spinal cord injury patients, most of them tend to have neurogenic bladder dysfunction, as much as 94% of the patients. And then they have other medical issues like traumatic urinary tract infections, stone formation, back pressure changes, which may lead to hydronephrosis and eventually damage to the kidney. Especially spinal cord injury patients are prone to develop pressure ulcers, and in the same subgroup or population, they may also develop autonomic dysreflexia, especially if the injury is above the D6 level. Then there are other issues, not only medical, there are physical issues, there are psychological issues. Patients have low esteem, guilt, depression, social isolation is a realistic problem, especially in patients with spinal cord injury who are otherwise fine, don't have any cognitive deficits. Domestic issues are there, occupational, they cannot rejoin their work, and they have sexual issues. So all these issues could be there because as a sequelae of the neurogenic bladder dysfunction. So once you know the patient is having neurogenic bladder dysfunction, what next? What you have to do? The patient is admitted with you in a rehabilitation unit. Of course, history taking, where you will determine what kind of bladder symptoms patient is having. Bladder diary, and I'll tell you in the subsequent slides. This is the most important initial tool to see what kind of bladder the patient is having. Then we want to do physical examination, urine analysis, urine microscopy. We want to do post-void residual. It can be done clinically, or it can be done by doing the renal ultrasound. So these are very important non-invasive tests. And we usually prefer patients who are admitted with us with urinary complaints in all spinal cord injury patients. They undergo urodynamic testing. So that will give us the guidelines how to manage patients' bladder. Then what are the urinary symptoms, bladder symptoms? The storage, there could be storage symptoms or there could be voiding symptoms. The storage symptoms occurring as a result of NDO or neurogenic detrusor overactivity. And we have seen in geriatric population, a lot of patients have idiopathic detrusor overactivity, which is not because of neural mechanism, but so it is known as the idiopathic. So NDO patients, the complaints are like increased frequency of urination, urgency, which is a sudden compelling desire to pass urine, nocturia, that is number of times patient has to get up after going to bed to pass urine during the night, or urgent incontinence, which is leakage of urine. Then there could be voiding symptoms like hesitancy, precipitancy, straining to void, interrupted stream. So these are usually known as the voiding symptoms of the neurogenic bladder. Then after the initial investigation, neurological examination is very important, especially in traumatic spinal cord injury patients. We want to determine the sensory level of the patient has sensations or not. Motor examination, we use Asia impairment scale to determine the completeness of injury or the severity of injury. Then all these reflexes, anal reflexes, anal tone, these are especially important in a rehabilitation setup in managing the bowel, making a bowel program, whether the patient has lax tone of anal tone is lax versus patient is having anal hypertonia. Voluntary anal contraction, again, which would guide you about the patient's completeness of spinal cord injury, whether it's complete or incomplete. So this examination is important in these patients. Then assessment, how do you assess or stratify the neurogenic bladder dysfunction? As I told you, this is a Canadian urology guidelines of how to manage neurogenic bladder. And they believe, and which is very true, patients with spinal cord injury, spina bifida, or advanced multiple sclerosis patients, they are more prone or more at risk to develop kidney injury in the long-term run. So these patients are always considered as the high-risk patient. So in these patients, once they are admitted and they have urinary complaints, so we want to do baseline urodynamic study. We want to do renal ultrasound just to see back pressure changes and post-void residual. And we want to see renal functions doing urea and creatinine testing. For other patients like patients of stroke, patients of traumatic brain injury, again, these patients have intact sensations. They want to do voluntary micturition. So again, maybe it is not mandatory to do urodynamic study. but you have to just maintain a bladder diary, decide about the management program, and then just take patient feedback and decide how to go about it. So as I told you, bladder diary is the most important tool to know what kind of bladder or neurogenic bladder the patient is having. So what are the components of a bladder diary? Usually once we see the patient, we ask them or their family members to maintain a bladder diary for 72 hours. And what are the components of this bladder diary? The fluid intake, the drinks, whether it could be tea, coffee, milk, whatever, what kind of drink patient has taken and how much patient has drunk over a period of 24 hours. Urine, how many times patient has passed urine, that will give us idea about how many times patient, what is the frequency of the patient and how much patient has passed urine. Accidental leaks, how many times patient has leaked and how many times patient had urge to pass urine and what the patient was doing at the time of urge or when they had desire to pass urine. So that will give us idea whether the patient is having stress incontinence versus the urgency and urge incontinence. So bladder diary and reviewing the bladder diary would give you a general idea of what kind of bladder patient is having. Then urodynamic study, use especially the traumatic spinal cord injury, and in our center we get more non-traumatic myelopathy cases, but most of them do have neurogenic bladder dysfunction. So we do filling and voiding cystometrography, and we know pressure flow studies are done by the urologist for different purposes. We know uroflowmetry is done patients with prostate issues. Sphincter EMG, we do surface EMG, and video urodynamics is required in certain situations. So this is our setup of urodynamic laboratory, where we do filling and voiding phase of cystometrography, and bladder management is based on the findings of the cystometrography. Especially in the myelopathy patients, what we have seen, the patients tend to recover over a period of time, and recovery could be both neurological as well as the functional. But the tricky part is UDS findings could change. As you can see in this one of our studies, where we do, patient had urinary complaints, patient had myelopathies, and patient had change in bladder character over a period of time. So what we did in this study, patients were followed up for minimum of 1 year after the trauma. So during the first admission, their UDS was done and it was repeated minimum 12 months. I think the mean period was 16 months. And as you can see in the tables, the patients continue to show recovery, admission versus discharge versus the follow-up after 1 year minimum, where functional recovery also is there. But if you look at the lower table, the patient's bladder tends to change over a period of time. You can see underactive detrusor, initially patient had 13. In the subsequent urodynamic study, only 5 patients had underactive detrusor. So they had gone into the overactive detrusor without sphincter dyssynergia. So this is another reason we need to repeat urodynamic study, especially in the initial spinal cord injury patient, whether traumatic or non-traumatic. Or whenever patient says the bladder character has changed, so we have to change the management protocol. So it is good idea to repeat the urodynamic study. Then coming to the supportive therapy. Well, supportive therapy is required for both spinal cord injury and other traumatic brain injury patients and other patients. We can advise them incontinence pads, disposable underwears. Condom catheter is a good idea in patients who are leaking, especially during the night time, patients with the spinal cord injury or traumatic brain injury, and daytime they are able to manage. So condom catheter is a good idea as supportive therapy. Then we can advise the catheterization. And as we know, clean intermittent catheterization is the gold standard for managing in the spinal cord injury patients. The advantages, they don't have sensory sensations. So we can do the periodic clean intermittent catheterization. Some patients would be required to undergo suprapubic catheterization, patients who are having some urethral pathology or fistula or stricturous form. So suprapubic catheterization. Whereas some patients, let's say like advanced dementia patients, very aged patients, Parkinson disorder advanced stage, would be on indwelling urethral catheterization patients. So clean intermittent catheterization, which was in a paper in 1972, Lapides advised this clean intermittent catheterization. And what are the recommendations for this? Well, it's a gold standard, as we already know, in the spinal cord injury patients, that the patient should have low detrusor pressure at capacity, that is low leak point pressure, minimum volume. So they must be avoiding good volume of urine. The urethra must not have any pathology. Patients should be compliant, understanding, and cooperative, and patients must have adequate hand function to do clean intermittent catheterization, especially for the self-catheterization. But it has its own limitations, like the patients who are tetraplegic who can't hold the catheter can't do it. So such patients can't do CISC. Traumatic brain injury patients with altered sensorium, patients who are agitated, who are drowsy, who are in minimal conscious state, patients who are in vegetative state, patients who have anatomical issues, like patients who are very obese who can't bend forward to do it, females who have to do it blindly, or the patients who are having poor functional capacity. Such patients are not good candidates for clean intermittent catheterization. And plus there are possible complications with this method also, like recurrent UTI, stricture formation, false passages in fistula. Then there are other non-catheter mechanisms which can be advised to these patients, like voiding, scheduled voiding regime, asking the patient based on the UDS finding, doing 3 hourly or 4 hourly or 6 hourly. If the patient is having element type of bladder, you can advise even 6 hourly CIC. If the patients have incomplete injury, pelvic floor muscle exercise is a good idea. The Kegels exercise, just they learn to hold the urine. Credes, Valsalva, suprapubic tapping, these methods nowadays are not advised, because no matter, even if the patient is having element type of bladder, there are always chances of back pressure changes with prolonged using the compressing of abdominal wall. So these methods should be discouraged, and they may exacerbate hemorrhoids, rectal prolapse, especially if the patient is doing Valsalva maneuver. Contraindicated in patients with detrusor sphincter dyssynergia, because these patients are more prone to develop back pressure changes. Then pharmacotherapy, if these supportive methods are not working, patients are still leaking urine, especially the patients who are having urgency and urgent incontinence. Antimuscarinics are the mainstream treatment. And all these medications in our center, nowadays we more commonly use tolterodine and solifenacin. Earlier oxybutynin was also used. The disadvantage with these medications are these are short-acting drugs, most of them, so you have to give BD or TDS. And to overcome this, probably sustained release is a good idea, where you have to give medication once a day to the patient. So you can minimize the adverse effect, at the same time have the optimal benefit of the medication. So there are reported adverse effects, anticholinergic effects with these medications. The most common being this dry mouth or xerostomia, constipation, sedation. And the important factor, especially with regard to the patients of traumatic brain injury who are already having memory attention deficits, cognitive impairments are there in patients with Parkinson's syndromes, patients with dementia, stroke, who are having cognitive deficits. So there, these drugs are, antimuscarinics may not be the most suitable drugs. So then we have to look for an alternative in these patients who are having urgency, urgent incontinence, and cognitive impairment. So a good drug or replacement would be mirabegron. Mirabegron works on the different mechanism, works on beta-3 adrenoceptor agonists. So patients with cognitive impairment, probably this is a good idea to start mirabegron, 25 mg usually we start, then build up, take it up to 50 mg. So it has minimal effect on cognition. It has good control over the frequency of urination. It has good control over urgency incontinence. As you can see in this comparative study of 2018, it is as good as solifenacin 10 mg in a lot of aspects. Dry mouth is lesser with mirabegron, constipation is lower, blood vision is not complaint. So this is a drug for the selected patients, especially who are having cognitive deficits. Then there are other medications which are tried, like sphincter outlet incontinence patient is having, especially if you see the patient with Kodai-Quana syndrome or lumbar plexopathy patients who are having urinary complaints. There, you have to start some medication if the patient is not responding. Usually we try TCAs with alpha-adrenergic agonists like imipramine, anti-DAP, 25 mg, 50 mg, 75 mg. But we have seen mixed results. Not all patients respond to these medications. Especially, and then the patients who are having underactive detrusor as per the UDS, starting Urotone or Bithanicol, 5, 10, 25 mg tablets. It is useful in hyperactive detrusor, but not in acontractile detrusor. But it has to be avoided in the patients who are having DSD or the dyssynergia. Then if the patients are having retention, just like prostate-like patients who are having outlet obstruction, not able to pass urine, not getting good stream, tamsulosin is a drug which we more commonly used, 0.4 mg once a day dose. So that helps in alleviating the symptoms of the patients. Botulinum toxin, which has been commonly used by the urologists, few urologists and few physiatrists, they have also started using this botulinum toxin. It is a second choice drug. Once the antimuscarinics or the mirabegron kind of oral medications are not working and patients are still having urgency and urgent incontinence, then it's a good choice. The doses would be 200 to 300 units, as you can see in this diagram. Don't inject it into the detrusor, but infiltrate it into the suburothelium, and then it will be absorbed. It remains effective as compared to skeletal muscles. The spasticity management in adult patients, where the Botox remains effective only for 3 to 4 months. Here we have seen it remains effective for up to 9 months. And in fact, up to 1/4 of the patients, it remains effective for up to 12 months or 1 year. So it reduces the frequency, urgency, and urgent incontinence of these patients. But interestingly, with repeated injection, there are some adverse effects reported. More common LUT infections we know, but there are certain other observations, like the patients develop bladder aging, like they don't develop fibrosis or the inflexibility of the bladder wall and fibrosis after repeated injection. So both the reduction in the luminal volume as well as the organ dimension. So this we have to keep in mind with repeated injection of botulinum toxin. Then there are bladder augmentation advised to the patients who are on prolonged indwelling catheters. So over a period of time, their bladder shrinks, bladder capacity becomes poor, compliance becomes poor. So these patients are good candidates, especially young patients, traumatic spinal cord injury patients are good candidate for augmentation cystoplasty. So we have to refer them to our urology colleague, and the literature suggests 70% success rate with this augmentation cystoplasty. But there are adverse effects reported like urinary infection, calculi, and rarely adenocarcinoma. Mitrofenov is another technique where you make appendix, use the appendix to make a stoma between bladder wall and abdominal wall, and the patients can do the catheterization using this. Patients who are having outlet incompetence, slings, again, it's a urological domain. The surgeons will be doing it, putting the slings to control the incontinence occurring as a result of sphincter or artificial urethral sphincter. Neuromodulation has also been tried, and it could be sacral anterior root stimulation, or it could be tibial nerve stimulation. In fact, some of our colleagues in CMC are working in this project. We are also part of this tibial nerve stimulation for controlling overactive bladder. There is a Cochrane review in 2016 looking for the effectiveness of electrical stimulation in treating overactive bladder, and it had a very rich sample size, but they believe most of the studies were of low quality. But what did the of overactive bladder symptoms, moderate quality evidence has indicated that electrical stimulation is better than pelvic floor muscle training, drug treatment, or sham or no treatment. So it is better than some other methods of bladder management. So in a nutshell, I think I am crossing my time. Yeah. So prevalence of neurogenic bladder is high following patient spinal cord injury. We need to investigate all these patients, and spinal cord injury patients may be brought to patients to undergo urodynamic study after 4 to 6 weeks once we get a definitive bladder pattern, not in the initial days when patient has spinal shock-like picture. And this helps in avoiding the long-term complications to the kidney also. And bladder management should be based on the UDS finding. Clean intermittent catheterization is the gold standard for management in spinal cord injury patients. Other patients, probably it has to be a mix of behavioral, supportive, pharmacological, and surgical intervention, rarely. Thank you.
Thank you, sir, for that quick review of the neurogenic bladder and its management strategies. One question, by the permission of the chair, I would like to ask as to the importance of doing intermittent clamping of the catheter in all our post-operative patients, especially those who are undergoing spine surgery. Is there any role of doing that, or is it more harmful than helpful? It
is harmful. Nobody advises this. In the last 2 decades, there is ample evidence. Even with element type of bladder, clamping would always encourage VUR, vesico-urethral reflux. So back pressure changes. So it is not advisable. Clamping is not advisable at all in any bladder.
Okay, sir. Would it, the way it is being perceived as that it would probably help in retaining the bladder capacity.
Yeah, it's an old notion. No longer holds true.
Thank you, sir.
It's very important information for us. We still do it.
Yeah, we all do it.
We still do it. Yeah, nice, good. I have a very common question. For how long we should catheterize the patient? When should we change catheter? Second, about the antibiotics, decision catheter.
Yeah. So usually we advise clean intermittent catheterization has to be changed every 3 weeks.
Okay.
We use K91, and if the patient has a larger diameter urethra, K90 can be used, but K91 intermittent catheter, every 3 weeks it has to be changed. And about the antibiotic, we don't treat asymptomatic urinary tract infection. There has to be leukocyturia, bacteriuria, and fever as per the recent guidelines in order to treat symptomatic UTI in these patients. Otherwise, we don't treat it.
Dr. Anupam,
yes,
sir, please you continue.
Please. When you advise self-intermittent catheterization, at what stage we should advise self-catheterization?
In spinal cord injury patients, whether traumatic, non-traumatic, first thing is patient has to attain adequate trunk control. In rare cases where the patient is having poor trunk control, we advise them to go for self-catheterization. We advise the family members. The one thing is the good dynamic trunk control. Patient should be able to sit for long enough period because the whole process is going to take 10 to 15 minutes. So good trunk control, adequate hand functions. Of course, tetraplegia is ruled out, and then the proper positioning, and then patient can start doing it. Females have to do it blindly. So even if they're doing it reclined position, we encourage using a mirror in the reclined position, supported sitting, and then they can do the, anyway, the urethra is small, 4 centimeters. So females can do it blindly.
In continuation of Professor Sinha's question, Dr. Anupam, we have seen our clinical practice that most of the time patient with head injury comes to the emergency and just as a protocol, they do catheterize. And so many times what happens once it is being catheterized, we don't know when to take it out. And to complicate the situation further, in our study, we observed even patient with mild head injury can have urodynamic dysfunctions. So are there any guidelines who patient should be catheterized and when, for how long, and what will be the indication to continue or to remove the catheter?
See, initially we don't know. The patient is having neurogenic bladder dysfunction or it is because of the cognitive deficits, the patient. So initial, probably 1 or 2 weeks when we are settling other things, most of the times patients are kept on the indwelling care. And suprapubic catheterization is advisable to cut down on the UTI. But we know suprapubic catheterization has its own disadvantages, like recurrent stone formation is much more common with suprapubic. So initially, again, the patient is coming after traumatic brain injury. We don't know whether it's a neurogenic bladder versus because of the cognitive deficits or because of the altered sensorial. Patient is not able to tell us. So indwelling catheter would be a good idea. And that time probably periodically changing the indwelling catheter. But what we advise in such cases who are likely to continue with indwelling catheter, we do the once a week gentamicin bladder wash with normal saline and gentamicin, leave it inside for 15-20 minutes and drain it out. So that probably we tend to control the infection.
Yeah.
So to answer your question very pointedly, I'm not aware of any strict exact guidelines when to remove it, when to change it. The guidelines, Canadian guidelines suggest 2 to 4 weeks it has to be changed. Pragmatically 4 weeks it is changed word over. If you see the Canadian guidelines. So we usually change it every 3 weeks, after every 3 weeks.
I think we need to have some baseline data. And in addition, we need to have awareness also between among all of us, including our colleagues, those who are handling traumatic brain injury cases. Even sometime in a conscious patient, you will find that emergency, they have catheterized and these patients do have urethral rupture also in addition.
Yeah.
Traumatic.
And if not even rupture, the prolonged catheterization often leads to a subclinical infection leading to later on strictures, and so it becomes a hell of an issue for the patient in the long run.
Bladder capacity also goes down. The longer you keep it in the bladder capacity also goes down. So that is another long-term issue.
Sir, regarding the bladder capacity, again, we have a patient who is going to be bedridden with low sensorium for a long time on bed, and the patient has to be catheterized. Now, in order to maintain that bladder capacity, shouldn't we be putting that intermittent clamping for say few hours every day?
No, I think suprapubic catheterization is better option in this patient.
Maybe, sir.
Yeah.
Sir. Thank you, sir.
Yeah. Thank you.
Sir, with your permission, Sinha sir.
Yes.
Can we begin closing this session?
Yeah, sure.
Today's session.
Let's, sure.
Yeah. So on behalf of the WFNS, AASNS committee, and especially Professor Sinha's efforts, we thank everyone who made this webinar such a success. I think everybody enjoyed it, and we had so many questions which were so aptly answered. Beginning with the formal vote of thanks for today's session, first and foremost, we thank Professor Sinha, who is the chairman of the WFNS Neuro-Rehabilitation Committee, as well as of the AASNS Neurotrauma Committee, for initiating such webinars, which are very informative and very helpful to everybody. We thank our eminent speakers, Professor Russell Andrews from United States, Professor Rubiano from Colombia, and Professor Gupta from Bengaluru, India. They have taken off time from their busy schedule, especially our Western counterparts. It's a very odd hour for them, very early in the morning, but they have shown their dedication and their devotion to the specialty. They in bringing us up in overall rehabilitation of the patient, that they could spare time and give us such wonderful talks. I thank our panelists again, Dr. Sinha and Dr. Agrawal, for taking out time and helping us formalize and formulate this webinar so that it becomes useful to one and all. Thank you, everybody. Thank you very much. Thank you, sir. Over to you.
Okay, bye. Thank you.
Thank you all.
Bye, sir. Bye, sir. Thank you.
Bye now.
Bye, everybody. Thank you.
Thank you, Rubiano. Thank you, Russell.
you.
Thank you
Thank
to
you.
all. Thank you for your participation.
Thank you, Amit.